Retina Rounds podcast number 21. As part of our Giants in Retina series, Retina Rounds is honored to welcome Dr. Donald D'Amico, Professor and Chairman of Ophthalmology at Weill Cornell Medical College. Throughout his storied career, Dr. D'Amico has shaped the careers of countless ophthalmologists and vitreoretinal specialists. He is an internationally recognized leader in our field, having served as president of the Retina Society and Club Jules Gonin, and for his many surgical and educational contributions to our field, he received the Life Achievement Award from the American Academy of Ophthalmology. In this podcast, Dr. D'Amico talks about the people who shaped his career and the sources of inspiration that sometimes come from the most unexpected places. Let's check it out.
Welcome, everyone, to our weekly Retina Rounds podcast. This week, as part of our Giants and Retina series, we're honored to have Don D'Amico from New York joining us. Don is one of the true giants in Retina, has made innumerable contributions, both that he's been credited with and that he's made behind the scenes. And he's been, I'm honored to say, one of my consigliaries throughout my career and has given me great advice throughout. So Don, welcome to Retina Rounds, and thank you very much for joining us.
Well, Steve, it's an absolute pleasure to be here, and thank you for the very generous, if not highly exaggerated introduction.
Well, they're the best kind, aren't they? So, Don, tell us what your day was like today in New York.
Today in New York, so I got a haircut, not especially for you, but I did start with an early morning haircut, and then I went to the gym, which I have done pretty much 5 out of 7 days for 30 years. I always find 25 to 30 minutes to do something. I'm not sure I like it, but I always go to the gym. I feel it's really important to stay fit, especially given an Italian cardiac history that I managed to inherit. Then I came to work and I had patients. There were a number of people. There were 2 international patients, both who need an artificial permanent keratoprosthesis. One was a multiple failed corneal transplant associated with uveitis, and another was a patient from Africa, from Morocco, with a glass injury years ago, normal posterior segment, but had failed multiple PKs due to scarring in the front of the eye. So those were really interesting to see. I have new residents, of course, new fellows today. It's early in the year. I also did some administrative work. There's always stuff going on in the department. And so I'm ping-ponging, as I'm sure you know, between my office where there's some fire I have to put out, and then patients, which I love, and the teaching aspect of it. And then I ran out and got myself a quick coffee so I wouldn't embarrass you and me during this interview. And here we are. But a fairly typical day apart from the haircut, I would say.
So tell us about your job running the ophthalmology group at Cornell, one of the storied institutions and truly one of the historically great departments in retina, with contributions going back many generations. What's it like running the department?
Well, thank you. It's changed a lot. Let's start with that. So, for the listeners who are either contemplating being chairs or are in fact chair timber, so to speak, I would say that the job is today nothing like the job that it was when I took it. I've been chair now for a little over 18 years, which is obviously
come on, Don. It was like last week that you were at Harvard.
No. It's 18 years here in New York. Wow. And when, I can say a lot about it, but let's start with this. Chairmanship jobs today are incredibly diverse depending on the person, the institution, the times. So, for example, when I began, I am probably a fairly traditional chair model in that I'm heavily surgical, heavily teaching, kind of the surgical chair, figure in ophthalmology, as opposed to being a research chair, of which there are many excellent examples. Somebody like Russ Van Gelder just eclipses all of us with his ability to be a great chair and also do, pace setting research. And there are many others. or a an administratively gifted chair, someone who has got his MBA and knows how to reorganize institutes and all of that stuff. So I was started as a traditional model, but then the job keeps changing. When I started, I had four faculty and one that I inherited. Everybody else, when the changeover went, they parted with the department. So there's one holdover, and I brought four, and one of them I'm married to, my spouse Kim Sipple, who is the head of our cornea service, and the other two were Chris Starr, and who is a famous cornea specialist with us, and Paul Chan, of course, whom you know, who's now chair at University of Illinois. But things start getting bigger and bigger, and then the day-to-day stuff that, seeing patients and teaching medical students, you start getting involved in medical college and hospital committees. And then you have a pandemic hit, and then, things are changing, and then there's all kinds of changes in healthcare. And basically now I spend I claw my way back to the clinic and the teaching and the things that I really love, because there's this enormous demand for me to do strategic planning for the medical school and for the hospital, to become involved in outside initiatives, satellite building, et cetera, et cetera. So in many ways, it's become a much bigger job, but less ophthalmologically focused. And I really love the fact that I've been able to grow with that participation in bigger initiatives. For example, we are looking at working ever closer with our hospital partner, and that takes a lot of work because we have an unusual structure. We have two medical schools, Columbia and Weill Cornell, attached to the same hospital. And so there's certain things, and I collaborate very well with Jack Chaffee, my partner chair at Columbia, but there are things in which we have to iron out differences and all. But I think it's still a fantastic job. I'll tell an anecdote. I know you're hungry for no, I'm teasing you. You're hungry for anecdotes, but I,
Absolutely.
I didn't want to do chairman. I didn't want to do a chairmanship, and I really resisted it. I would get an occasional invite, come interview for this and that. And I was on the study safety committee for Macugen with, talk about two luminaries, Arnell Patz and Alan Bird. And about 20 some years ago, I'm in a car in Orlando driving Alan Bird to one of those ridiculous themed hotels where we're going to have the data safety committee meeting. And he said, well, Don, have you ever thought about being a chair? And I said, no, you know, uh, Professor, I really don't think that, Arnell, that I really don't want to do it. He said, stop the car. I go, what? He says, stop the car. So I pull over to the side, uh, and he says, ophthalmology needs strong leaders or we will go down as a specialty. Don't you shortchange that job. I want you to make sure. I mean, it was like the voice of God. I didn't,
This was Arnell Pass telling you this?
Arnell Patz. Yeah, I mean, I'm not a Wilmer person. I love Wilmer, but I'm not one of his goslings, so to speak. But we became warm friends, and he was so clear about the need for people to reach out of themselves and extend and become chair, that I looked at him and I said, wow, I'm going to really take this seriously. And, things worked out that they were looking for a chair in New York. And I'm a big city person like you. And I saw that there was a lot that could be done with this department. And that's proved to be true. But I needed a push, and it came from a most unlikely but incredibly noble source, Arnell Patz giving me an impetus to be open to looking. So I share that for what it's worth with others who are wondering, what is it like to be a chair candidate? I didn't know what it was like. I say you have to be good at ophthalmology. You have to be willing to let others be in the limelight, and you have to prepare yourself for a virtual uncontrolled luge ride of issues that will, come at you that you can never expect. I mean, look at the stuff we're dealing with now, indirect cost cuts and all of that. What do you do with that? Where do you get the manual for how to deal with that? So that's my long précis on how I view my chairmanship. I love the most hiring faculty and mentoring them. But as you know, I'm also really drawn to the whole teaching aspect of my that part of my career, whether it's from the podium or in the OR or side by side in the clinic. Uh, I would miss something if I didn't have that.
Well, full disclosure to our listeners, Don's program turns out some of the best trained American ophthalmologists. And in the program I worked in for a long time at UCLA, we highly prioritized his candidates, and we've had the privilege of sharing trainees in both directions, trading fellow candidates all the time, and uh, just spectacularly trained and set apart from the fundamental knowledge base with fantastic perspective and judgment, which is partly inherited, but very much a product of the environment there. And so, congratulations on the work product that you consistently churn out.
Well, I would
So,
just
go
go
ahead.
ahead. I was going to say, it's certainly not me alone. I was very lucky in that there was a need to build a faculty. I mean, a department of an institution this size should have about 60 ophthalmologists, and we had five. So there was obviously room to grow. And if I made one mistake, it was picking faculty that are over uh, developed in generosity of the spirit with regard to teaching. I mean, I hope someday to have room for crazy professors in towers who do stuff that, we can't really talk to them, but is important to the world. But we started with people who were really willing to teach and were excellent in their specialties, and it's had a very positive result on the trainees.
Well, your faculty are spectacular across all the fields. Chris is amazing, and there are a number of other anterior segment docs who are amazing. But I'm a big fan of Szilárd and Kish, and the work that you two have done together has just been groundbreaking. Tell us a little bit, though, as we pivot to the history of your department, because in retina, it is a storied history.
Well, the department was a division for a long time, probably longer than it should have been. And for a while, Dr. Schaefer, famous for the Schaefer sign, was the caretaker of the department here. He was actually based at another hospital. I think it was Manhattan Eye and Ear. I can't pull it up without notes, but the department really languished. And then they hired John Milton McLean, and he was known at Wilmer as the King. He was the brightest guy in ophthalmology at Wilmer. And he went from Wilmer residency to here. And he's often thought to have been the youngest chair although it was still a division, they considered it a chair. He was the youngest chair in American ophthalmology at the time. And he was a true polymath and genius. He invented tonometer. He invented the famous McLean suture. You may not have done it, but for intracap, it was a way of pre-placing sutures and then sweeping them out of the way so that the cornea came back to the same position. Otherwise, you wind up with 9 diopters of irregular astigmatism. And
I did use the suture, but I
oh, you
also,
did,
well,
you did.
but I did wind up with 9 diopters of astigmatism on a good day.
Yeah, so he came here and he really brought an amazing thing. So he trained a number of really important people, notably Edward Norton, who asked, for some space, and he really wanted to develop ophthalmology. And they kind of said, gee, no, why don't you go somewhere else? So that effort lost us Ed Norton and created the Bascom Palmer Eye Institute. We also had Vic Curtin, who became his number two man. He was a product of this department. And of course, Harvey Linkoff was here as the preeminent retinal surgeon, developing all of his incredible work with non-drainage and using things. And then Jack Coleman came over from Columbia to be chair after McLean unfortunately passed fairly early in his life. And Jack developed the whole ultrasound thing, which really brought additional luminance to the department. And one of his great good moves was to hire Stanley Chang. And so Stanley, working with Harvey and Jack, developed, a zillion things. I mean, Stanley is the neutron bomb of retinal surgery. He developed, perfluorooctane for giant tears, novel approaches for PVR, wide field visualization in a really practical way. And so that, and then they hired a number of other people who were here to work alongside them. But with superstars like that, the place really not only went from being just a languishing division, but it became a department, a very strong department, and a notably retina focused department.
I remember interviewing for the fellowship with Harvey and Stanley and Jack and being just blown away by the gravitas and the warmth, the accessibility of these just giants in our field, and so impressive, so impressive. And so let's talk a little bit about your journey. How did you decide to be a doctor and come into ophthalmology?
Badly is the way I would start, and haphazardly would be the two. I've told this story before, but I had no idea at all that I wanted anything to do with medicine. None, zero. And I was in college at MIT, actually, studying chemistry. I wanted to be a chemist, not a chemical engineer. I tried that briefly. I wanted to be a chemist, mixing test tubes and all that. And I was very focused on that. And then I was approached by a TA, a grad student who was supervising our labs. And he looked at me and he said, D'Amico, so what polymer are you going to work on when you graduate? And I was like knocked over. I'm going, what are you talking about? What polymer? And he says, where do you think the jobs are in chem? They're all in paints and polymers. And I just was like blown down. I was a Billy Boy scientist with, logwood in the chem. Did anybody ever figure out what logwood was used for in a chemistry set? I never did. Churning copper sulfate blue and stuff. And suddenly I'm going to be working on paints and polymers for the rest of my life. So I ran down the corridor and I found my advisor literally in a panic. And I said, I just got to do something with people. I'm not, and I saw a sign for the PSATs, the MCATs, and I said, "Is there any way I can take this test?" He said, "Well, the test is in like 5 days, but maybe I can call the registrar and get you a copy." So I literally never thought of medical school until well into college, and then I got really lucky and got into medical school. I was a hippie at the time, and I had not this length. I had, really not quite waist length, but I was up there, waist length hair. And I wanted to go back to my state school. So I went back to University of Illinois, which is completely another story for medical school because they had no experience with long hairs. And that was just a totally wild time. But and then I, found myself with Marilyn Miller, who you probably know, Academy of Ophthalmology award winner for her humanitarian service and a longtime strabismus expert at University of Illinois, and she became my mentor by happenstance, I think. And so I was drawn into the penumbra of ophthalmology.
And you just happened to be attached to her, or did you seek out ophthalmology?
Well, I think as it was, what happened was I left medical school. Okay, I didn't want to reveal this, but I will reveal it to you because you're a friend. After first year, I hated medical school so much that I quietly left. I had been accepted into a program called the James Scholar Program, which meant you could take uh, courses anywhere in America or probably the world. And, if you could get an approved clerkship or a class, you could get University of Illinois to give you a degree. So the first year, though, you had to do in the lecture hall. And I went into a lecture hall with, I don't know, hundreds of kids. It's one of the biggest medical school classes, and I couldn't do it. I could not do a massive lecture hall about biochemistry again. I had a degree in chemistry, and I said, no, I've got to do something more active. So I left medical school and went to work with a really charismatic neurologist in extrapyramidal diseases, Huntington's chorea, Parkinson, named Harold Klawans. And he took me into his lab, and the next thing I know, I'm feeding amphetamine to rats and making them have tardive dyskinesias and stereotypic behavior and suppressing it. So I became a lab guy for him. And after a year of that, I started rounding with the neurology residents. And Marilyn, who I believe had been pre-assigned to me, she said, "Are you coming back to medical school?" And I said, "Well, I don't really know." And she said, "Well, there's this great guy in ophthalmology that does neuro-ophthalmology named Mickey Rosenberg. And he's in Chicago, and Mickey would take you for 2 weeks if you want to see if there's any crossover with neurology and maybe ophthalmology." So I did 2 weeks with him, and he was tremendous. He still is tremendous. And he said, "Don, you ought to go to see the guy who trained me. He's really fantastic. His name is Bill Hoyt. He doesn't take medical students, but I'll see if I can get you." So I went to your neck of the woods. I came out unsure about going really back to medical school, and I went and spent 3 months with Bill Hoyt, which was, of course, transformational. I mean,
Right.
and who was on the service at the same time. You probably knew him, Jorge Alvarado of the EM
Sure.
book fame. So he was a resident doing his book and would spend time with Bill. And I was a medical student, also with a guy you also probably know, Ray Oyakawa, who was in the department there. And after 3 months with Bill, he called me in and said, "You should be a neurosurgeon. You've got what it takes. You can be a neurosurgeon." I looked at him. I said, "I don't want to be a neurosurgeon." He said, "No, no, no. Okay, okay. Then if you can't be a neurosurgeon, be a neurologist." And I said, "I don't want to be a neuro." He said, "Oh my God, you're going to do what I did. You're going to become an ophthalmologist." And I said, "Yeah, I think I." So he was really instrumental in writing a letters that I wish I could have seen this letter, but the next week, all the chairs were asking me to come for interviews. I mean, he really took me from one place and brought me into my career. And we remained fast friends through the Aspen Retinal Detachment meeting, which he loved to attend throughout his life.
We all love to attend. And I would just say, anybody who hasn't attended it, the Aspen Retinal Detachment Society should, because it's a true treat. One of the great collegial academic exercises one can go through.
Well, great. Thanks for saying that. I still managed to get myself up on skis, and even though I've been down in the meat wagon a few times in my life, I will not stop until forced. So, but I
Well,
owe
look,
I owe
look
Bill
for our
another.
listeners out there. The first time I came to the Aspen Retinal Detachment Society, I think as a speaker, you looked at me, Don, and said, "We're talking about who's going to ski with who," and he said, Don says to me, "Do you need to see God?" And I said, "No." He goes, "Okay, you're not skiing with me."
Yeah, those were the days. Those were the
Yeah.
days. Bill was a
And,
spectacular skier, by the way.
yeah, and great man, and just so lucky. It's the brush with greatness, the fortuitous brush with greatness, and then having him recognize your skills is so so wonderful. And then where did you end up training as a resident?
Well, I got lucky again in that I went to the interview trail. I got interviews at a lot of great places, but I had come from, Chicagoan, but I had loved Boston when my college at MIT. I loved it. And so I got an interview with Klaus Dolman at Mass Eye and Ear. And there was just something about Klaus that I knew I would learn and grow to love, which, I mean, he has become, he recently passed, and, he at 100 plus, and I stayed connected to him and co-worker with him even here in New York and trained his grandson, Tom. I just felt that the Mass Eye and Ear was the right place for me. I mean, it was a war zone at the time. The fellows were fighting with the residents, were fighting with the voluntaries, were fighting with the full-time. It was not one happy family. But I knew that I could thrive in a place with a zillion people and a big institution, and I loved my residency there. And plus, I got exposed as much as a resident could to the whole Scapins tradition of sclero. They were a private group by then, but Charlie Regan and Evan Gregutis and others on the retina service were both, Charlie was a member and Evan was a trainee long ago. And so I had that whole Boston retina tradition, which I really got a lot out of. And it was a tremendous, I'm sure you know it well, it was a really phenomenal residency. And then at the end of residency, um, Taylor Smith, who is a little known figure apart from those who knew eye and ear, who was a phenomenal retinal surgeon and eye pathologist. He, I had done a presentation on lattice and all this for him at the conference, and he came over and he said, "Don, what do you want to do?" And I said, "Well, I'd like to do retinal surgery." He said, "I want you to talk to one of my students, Vic Curtin, at Bascom Palmer." And so I wound up interviewing at Bascom Palmer and with Tom Auberg at Milwaukee, and both were very open. But again, I felt the wish to be in a really big institution. And, Curtin and Norton and, Blankenship and Clarkson and Blumenkrantz and all of those people, Harry Flynn at Buddy Culbertson, all the Bascom Palmer faculty just became dear, lifelong friends and helped me enormously. So I was super lucky, Steve. I got the best of Boston, and then I got their competing school, the Bascom Palmer, and what could be better?
Nothing. Honestly, that time at Bascom, and frankly, that time at the Ioneer in Boston was the golden time. I mean, they're both you know, come and gone and come back again multiple times, but they're just amazing, amazing faculty and what a cohort. So who were your co-fellows, or was it one a year at that time?
We were five. Jim Tiedemann was the Don Gass Fellow for a year in macula. Then Lee McLean, who is in Asheville, North Carolina. John Olson, who is in Florida. Lee Anderson, and Calvin Lee Anderson, who was in Texas, and Calvin Mine, also in Texas. And we've remained close. It's been great. We all went off in different directions, but lived and usually on Key Biscayne and shared a lot of dinners. It was a fun thing because at Bascom Palmer, the faculty and the fellows were really close. So there were, weekend softball games and beach trips to Key Biscayne, and really kind of a fantasy year to live in that magical environment. It's funny because Tom Auberg, who also worked with Mockamer some years before, he describes it differently, and he's gonna, if he see, I doubt he'll see this, but he would laugh. He said, "All I ever saw of Florida was the Key Biscayne Causeway driving back and forth to Mockamer's lab." But he
Well,
also loved the place.
there's nothing not to love. And let me just ask you this important technical point. How long was your hair when you interviewed with Vic Curtin?
Oh, it was very short.
Yeah,
It was
because
very
my
short.
hair was just about to my ears, and he told me it was too long. Uh, but what a great privilege to be there. And then you decided, coming out of fellowship, which is the reason I've asked you these stories. How did you decide to go? You went straight back to Boston out of
Yeah,
fellowship.
well, I did. I did. It was a little weird in that I thought when I left residency that I was going away to come back. But when the fellowship, I was only a 1 year fellowship at the time. As the fellowship is going on and on and on, I'm waiting for Mass Scienter to call me, and they're like, hey, what's going on? So I finally called Charlie Regan, and I said, I'd like to put in for an RO1 grant and do some research. And do you really want me back? And as it happened, one of the attendings, the only attending other than Evan, who was vitreous trained, abruptly left and went into private practice. They would have asked me back anyway, but they said, "Oh, absolutely, we want you back." So I get there planning to spend a year doing lab work, get that running before. And Charlie Regan looks at me and says, "We have no one to manage the diabetic unit and do all the emergency retinas. can you handle the diabetic unit? I said, yeah, I know how to do traction detachments, and they were bad, as you'll remember in the early '80s. No endo laser. Uh, so
No
the next thing,
GLP-1 agonists.
no, a lot of stuff. No
Yeah,
anti-VEGFs. No.
yeah.
So in coming back, Steve, in the first year back as a quote newly created position, a la Wilmer, chief resident at Mass Eye and Ear, only a couple of years old, that they had a fellow come back. I did 180 cases in Boston in my first year. I mean, who does 180 cases their first year out of fellowship in Boston? And it was an amazing training. All the trauma, all the GTs, all the diabetics, the PVR, everything came to me because no one else was really available in the full-time faculty to do it. But after that year, there was an interesting moment of political uncertainty, in which case the voluntaries, which gave privileges, said, well, we're not really sure. We think it's a good idea for Don to move now into a faculty position on the full-time staff. But they ultimately listened to Klaus Dolman and Evan Gregutis and Charlie Regan, and they gave me a position on the retina service, where I remained for almost 25 years, just loving it, training fellows and doing zillions of cases. So I started out thinking I was going to be Joe RPE, antibiotic toxicity from antibiotics, kind of RPE. Rob, I'm blanking on his name, from San Francisco, the famous RPE research. That was what I was going to do, that kind of research, and I was whoosh, redirected into a hyper surgical career, which obviously I loved and has suited me very, very well. But all by fluke, and also as a result of people, wonderful people who took me under their wing or asked me to do things.
So there was a lot of good fortune there, but in those days, the decision tree was a little different than it is now. Contrast for us the difference between your decision to go private versus academic in those days versus what you counsel your current graduates on how to choose.
That's pretty easy. We knew nothing. In our generation, we knew nothing. I can say this completely honestly. I did not even know that ophthalmology was considered a lucrative specialty. I had no idea. Okay, when I started, I had no idea what an academic career was. I did not realize that I would travel a lot. I did not realize that I would need to know multiple languages, or that it would be an advantage. I didn't know that there would be this mix of I had some vague idea, because obviously that's where we all incubate, but I didn't know what it would be like to have that as a lifestyle. Now, now, uh, this part you will probably consider editing out. No, I'm kidding. But now the questions that people ask because of the change in times is all about lifestyle. If I choose academics, how many days a week will I be expected to work? What are the work conditions? What are the work hours? If I protected time, that's the issue. I want to earn the salary of the highest volume private practitioner in the area, but I also want to be able to do it on my own terms, 3.5 days a week with a day and a half of protected time. And we look at them and wonder, right? Wonder where will that funding come from? I remember doing rabbit experiments on the late weekends in a bathroom in the Howe lab, because that was the only time available to me to get the stuff that came from my earliest publications. And I don't begrudge the young. It's a different world. They grow up now working remotely. They see what their peers are able to achieve and accomplish, but it's so completely different. I mean, I feel like a guy coming home on the GI Bill in 1946, and having a career then, compared to somebody now who sees a completely different world.
Yeah, it is a completely different world, and I also very much respect the questions that you're relating that come from our trainees. But part of my coaching tree is from Taylor Smith because of Buzz Krieger, Taylor being from Pasadena, then Boston, and Buzz Allen Krieger, who ran UCLA before I did in the retina group. And, the truth is, if you do what you love and you take good care of patients and you have actual inquiry in your scientific pursuit, um, everything else follows. And, or at least it did for us. And we were so fortunate to live in a time. I have such clear memories of watching you give a lecture in Italian. Okay, that's fine, you're Italian, but how about Greek? How about watching you in Japan or, being together? I can't even list the number of places we've been fortunate enough to be together around the world. And so
Well,
I
I
think,
remember you helping my oldest son edit videos on the airplane in Japan. I never thought that was possible, but you were there and you guided him through. But I forgive me for interrupting, but you the same. The energy that you bring. You have never wanted a day for work in your life. I'm sure things come to you because people know that I can give this to him, whether it's stem cell trial or something new or innovations in ROP, retinal detachment approaches. Things will come to you if you make yourself available. So let's share that as advice to the young people listening. Follow your energy, make yourself available to things, say yes when you're asked to participate, and you'll get into a rhythm where things are presented to you to to be part of. I don't plan in a big way what I'm going to do next week. Somebody says, "Hey Don, we've got a research project. Would you be willing to look at some histologic retinal slides?" And the next thing I know, I'm in a new research project.
yeah, running it. And the next thing I know, I'm getting an invitation for you from a Lasker Award winner to have dinner in a few weeks. And it's like amazing what happens. For the audience, one of my favorite Don D'Amico quotes, and I can't remember who we were talking to. It was one of our co-trainees. And you said, you're going to come out of fellowship and you're going to be trying to stimulate your practice, and you're never going to know what the perfect day was because shortly thereafter, you're going to be trying to regulate flow at Niagara Falls. And good luck with that. And it's true. We're so fortunate to be needed and to be able to contribute. It is really incumbent upon us to say yes. I think that's great advice. And I think it's important to follow your own energy. That's a really good way of putting it. And it's different than trying to micromanage your time off. And it's probably great for this generation to be able to do that. It's just completely disparate and dissonant for me to think of things that way. I think you learn by doing, I learn by doing, and I learn by participating, and you contribute. And one of the great themes that comes out, and I'm sure it's going to come out in this discussion, is what makes this so meaningful is the sense of contribution that you get to make, whether it's to academia or to individual patients or to whole populations. I mean, you and I had the privilege of working with the great teams, bringing forward the anti-VEGF drugs and so on. So we'll circle back for that. But while we're on the history subject, I just want you choose one anecdote about Evan Grigutis, who I just love. And so share your favorite Evan Grigutis story. If I know with me, he tried to convince me that I was Greek when I'm clearly not. I don't know what your favorite Evan Grigutis anecdote is, but I'm sure, and edit this so that we can show it.
No, no, no. I have many. I would say that one of my favorite Evan Grigutis stories is that we're standing on a bus stop in Greece in a small island, waiting to get back from the beach, and there's like nine of us, all Greeks, and there's me. And we're all, kind of wearing, sandals and bathing suits and a t-shirt, and we're all waiting for this local, shuttle bus that comes every hour. And a man, an average person, comes up and looking at the nine of us, he comes over to me and starts speaking Greek. At the time, I was the only non-Greek speaker. And so Evan kind of loses it. He goes, "Can you believe out of all of us, he's the one that they pick as the Greek guy?" So that was it really got under his skin, and I loved it. I just
Yeah, what a
totally
classic
enjoyed
moment. What
I
a classic
totally
moment.
enjoyed I totally enjoyed that.
So, Don, switching gears to of all the innovations and all the impactful things you've been lucky enough to be a part of, what do you choose the top one or two, maybe medical and surgical, biggest innovations that are impacting our patients today, and maybe share a little bit about how they came about?
Well, I'll start with the one that's probably the most unusual, and the one that I mentioned that I got to work with Klaus Dolman on, which is rehabilitating eyes with permanent keratoprosthesis. Interesting story about Klaus and that device. As a young man, he was actually briefly a retina fellow with Scapins, but he didn't want to do retina, and ultimately, of course, became one of the world's, if not the world's greatest corneal expert. But he started working on permanent keratoprosthesis, and then chairmanship hit, and he gave it up for a while. He said, "This is not a young person's project. This is a project for an old person, because a young person needs success right away in order to get on a podium, to get grant, whatever, but an older person can take failure after failure after failure." So he shelved it for like 25 years. And then when I was a mid level attending, he revived the project. So I was not being presumptuous, I was his right hand man. We'd go into the OR, and sometimes, Steve, we'd work for 40 minutes to find the eye. We would, painfully separate the Stevens Johnson scarred lids, and then we'd take off the pannus, and then finally we'd find the eye. And then he would open find the cornea, and then I would do whatever I was going to do, open sky, and then later closed. And we would do these cases together week after week after week, and it kept getting better and better and better and better, and published a lot. And now it is something that still there's tremendous problems, and a lot of people don't want to do it because the cases are so tough and the results are so, different compared to doing a standard RD. But it's become incredibly satisfying. And his grandson, Thomas Dolman, it now manages the K-Pro project at Mass Eye and Ear, and helps us manufacture the K Pros. And it's also fun that I get to do those with my spouse, Kim Sipple. I'm not sure I'd recommend operating with your spouse. It's just not for the faint-hearted, but it's
I've
a
done
lot of
it.
fun.
I've
Yeah,
done it, and it's humiliating because they're such better surgeons than we are, at least in our
yeah,
cases.
yeah. So anyhow, but I think the whole K Pro project has been really, really helpful to me. Something that professionally that I enjoy. Second thing, I'm not sure that I think that the part that has given me a great deal of satisfaction is being kind of involved in uh, society work and clinical trials work in a very in a way that has given me a sense of being fair and objective, whether it's proposing new members for society or helping a society find its legs or participating in a safety committee or clinical trials design committee. I enjoy that work a lot. And that is something that's become a big part of your life, but also of my life. It's not anything I would have predicted, right? I mean, who knew that we would become involved in developing clinical trials, and also in working with Retina Society, Club Jules Gonin, ASRS, the the editorship, and I know you've commented to me personally about this, of
Well,
creating
I
the
was just going to
JP.
go there. The editorship is something we need to talk about. So, I
So
mean, what
let's
a
hold it
huge
for a sec.
contribution.
We'll hold it for a second, and I would say, and also the work that I've done in retinal detachment, in trying to understand, the place of retinotomy, the place of vitrectomy, the place of uh, membrane peeling versus membrane suppression, the place of lensectomy, the place of scleral buckling. I've tried to work with these issues as objectively as I can, and usually it's taken the form of, uh, you know, presentations at podiums, or else discussions with knowledgeable colleagues, or even debates such as yourself. But it's given me a real fast. The fact that people think of me as knowing anything about retinal detachment, when I knew Scapins and Norton and Curtin and so many of the people, and Taylor Smith and Buzz, so many of the greats, uh, Mockimer, the fact that I even have an atom of that, I mean, it's enough. It's enough for my life. I don't need to do anything else that somebody would think that I almost knew something about that subject, which I utterly adore. So that's sort of, the teaching part I won't go into because I've mentioned it, but I'm in this most of all because I love to teach and develop young people and young faculty. I'm saying
There's
too much, but
no, it's fantastic. And that's exactly what our listeners want to hear is the inspiration satisfaction quotient that stays fresh throughout a career. It's so different than measuring yourself by uh, income, EBITDA, which is great. It's a great thing to do, and you can do great things. But there's another way forward, I guess, is what I'm saying. And one of our former fellows said, if I can be like Buzz for one day of my career, I will have been a stunning success. And I know you awarded him with a Taylor Smith lecture in Aspen, which gave him more satisfaction than any of the myriad awards he won. And it was just so special to him. And he used to say things to us, respect the tissues. That Taylor used to say, he said, this is what Taylor would tell us, respect the tissues. The operation starts at the physical exam. He just had
oh,
all of these aphorisms that just, I'm sure, give you
when
goosebumps when you
when
think
he
about it.
gave the lecture, you could feel the resonance of sincerity and honor in his chest that he had for Taylor. I mean, it was an unbelievable lecture, all based on, uh, the Egyptians have this idea, and it came later into Star Trek about carrying the katra for somebody, the emotional and spiritual energy. He literally imparted to the audience, or tried to as best any human could, the what he got from Taylor. I mean, we're all vessels that are being poured into by these people who, when you think about it, really had no need to do it. I mean, what was in it for, Bill Hoyt or Dolman? But they're superhuman beings, and they gave us all so much, and they continue to give us all so much. And Buzz felt that way about what he got from Taylor, and he honored it by sharing it in that lecture, in addition to the daily experiences with all of you guys who were privileged to work with him.
And it was just the fact that we can cite Taylor as part of our tree is so spectacular. Let's shift gears a little bit and talk about the editorialship because you took that journal and elevated it dramatically. And I will say at the beginning that you've turned it over to the right editor, whether or not you actually had any choice in who the succession plan was. But I think Tim's doing a fantastic job. But let's talk about what it's like to be an editor. What are the challenges? What were your goals? What were your successes? And what are you happiest about the contributions? I can tell you from the front, my favorite thing were your editorials at the beginning. I just loved them. But tell me about raising the quality and what you got out of it and how you thought about it.
Well, I agree with you that Tim is doing a spectacular job. Let's
Unbelievable.
start with that. I mean, so, I had never been an editor, right? Now, I mean, who's been an editor, especially for a brand new journal? So the ASRS, called me up and said, "Would you like to do this?" And I'm thinking, well, I'm not really
Full
sure.
disclosure, I may have been on the board when we decided that, but anyway,
Okay,
go on.
I'm not really sure, but I enjoy writing. I enjoy contemplative time. And I said, okay, I'll give it a try. And they're thinking, well, what do you think about every 2 months? And I'm like, gosh, I don't even know if we have an article for every year, let alone every 2 months. So there was tremendous uncertainty on all our parts. And I looked at that and I said, well, what can I do as one person of course, I can ask my colleagues to contribute articles and submissions and all of this, but they're going to look at me. It's not PubMed. It's what am I sending my article to JVRD for? Maybe I can lure people or attract people by some lyrical essays. can I write a Lewis Thomas style essay about some theme in retina? And I looked at myself and spent a lot of time staring at the ceiling and then realized that every 2 months I had a deadline. I had to come up with a theme and warp it into some tangent that was interesting to me and interesting into the audience, uh, the readers, in order to attract readership. And it turned out, Steve, to be a wonderful experience in self discovery that I enjoyed my time with my word processor and trying to struggle for a theme and a cover and all of that. And I learned a lot about myself, that writing has always been important to me, as is speaking, and it's still important to me. And it's something that I hope to have the time to do more of when I leave, the trappings and all of that of a chairmanship. But so that really, I'm pleased that the journal has been a great success, and it will continue to grow and be even better and better with the great leadership it has and the strength of the society and the PubMed approval and all of that. But for me, it gave me a lot. I want to emphasize how much was given to me to rediscover those mornings, uh, writing and thinking and being open. I do not miss haggling with the reviewers nor the authors, I should say. It was generally very okay, but there were times when, uh, it can be tricky, and those are
Look,
all.
you have to have a position, and you have to have a philosophy, and you had one, and you stuck to it, and it was quality, and that's why it grew. You can't publish everything, and you can't acquiesce to strong-minded authors who think their paper is the gift.
Yeah, yeah, and it astonishes me even today to realize that I did 36 of those essays. I mean, 36 essays. So again, I am now trying to figure out what will I write when I suddenly have the time to do it. And I've had a number of professional authors give me advice and stuff like that. But self-discovery, this is what we're talking about. I just throw this out there as a completely left field comment. Our careers, the people we interact with, the trainees, the projects we become involved in, they're all great on face value, but they're also opportunities to deepen our self discovery. And in that, we find more and more about what animates us, and if we're open to it. So, you and I have been very fortunate to be in strong currents,
So
and I hope
lucky.
it continues. I hope it continues.
Well, certainly, being a juggernaut like you is part of you've made your own current through your dedication and your openness, and that is really part of the magic of academia, is being in an environment that allows for self-discovery and allows us to pass it on. It's funny you mentioned Star Trek, and I was remembering when I was a resident, I remember Buzz Krieger was taking care of Gene Roddenberry, who,
Are you
you know,
kidding?
no, who, I mean, Buzz's practice, our practices at New York and in Los Angeles are filled with these people that are remarkable. And uh, I remember the Gene Roddenberry thing, and I remember uh, Buzz was so funny because in the other room was, Frank Zappa. And so who Buzz actually had more of a proclivity for Frank Zappa than he did for television of any kind. I don't think he had a television because he was such a, man of letters. And so I remember telling him, look, Buzz, this guy is special. This is a special show. And he actually ended up loving Star Trek. But I can't remember what was the word you said, the pass it on thing from Star Trek.
Oh,
What was
Katra. I believe it's the Katra. It was
right?
it's an Egyptian concept, I believe, carrying the spirit of somebody, that it's viewed as the spiritual life that can pass from one person to another. I think I have that right, but
Well,
I'm sure there are viewers.
that's really what we do, isn't it? I mean, that's why I'm so fascinated by the history, and I would strongly recommend to our readers to go out and look at these essays by Don D'Amico and JVRD. They are short, and they are provocative, and they are exceptionally well written, and they will stick with you. And I hope that you publish them as a collection, Don. I think that they're worthy of that, and I know the journal owns them or something, but I still think they should be a
Oh,
collection.
thank you, thank you.
They're terrific. And by the way, Tim's doing a nice job at
Yeah,
that.
like we said, oh, I cannot believe the detail and the work he's put in and, expanded sections and reviewing. I mean, amazing. And he appeared early in my editorship and basically saved me because I was drowning with all the work. I mean, editors learn quickly that from 6 to 7 in the morning every morning, you are doing stuff otherwise you'll be so far behind, and Tim appeared and suddenly there were all these things that he was able to take off my plate.
Well,
He
the good thing
could
about Tim is he doesn't have much of a drive, right? I mean, this
yeah,
guy
right.
has a caffeine secreting tumor. I don't know what the deal is. He
That's
is
funny.
amazingly efficient. And he's taken over Aspen, hasn't he?
Yeah, well, he and I share Aspen, but of course he does all the work.
Right.
I'm just trotted out as a kind of a grand old man to make some snide comments or to engage the international speakers. But no, Tim is the organizer of that meeting and does all the hard work, all the
Which
heavy
is
lifting.
absolutely a must-have. And I think that journal is in great hands. I couldn't be happier. I actually still take it on paper. I love getting that actual journal,
Oh, great.
which is probably not as eco-friendly as it should be, but I like to
No,
touch
no,
that
no.
one. And well, listen, Don, let's just end on some future predictions. So, where do you think the next big innovations are coming? Do you think it's regenerative? Do you think it's gene therapy? Do you think it's certainly there will be better and newer molecules in the anti-VEGF, anti-permeability, anti-proliferation space? But what do you think is next for our field? Like, what should we be anticipating near and long term?
Oh, wow. Big question. Well, all of those things, I mean, all of those things are happening, and you've been in all of them. Certainly gene therapy, and I'm not so sure about stem cells. I'm really not so sure about stem cells. But I'm very sure that gene therapy will continue to grow and all. I'm not sure how we'll administer it. I think subretinal injection is going to fade, and that people will use intravitreal injection because it's just too ridiculous to have to tether gene therapy to a complicated vitreoretinal surgery. I mean, what do you care if the ciliary body is making your anti-VEGF compared to something else? So we'll put that aside, and I think intravitreal gene therapy is going to be come to the fore. I think we're going to develop partial thickness macular surgery. I think right now macular surgery, our surgeries have become more and more macular. When you and I started, it was peripheral retinal detachment and then macular hole and pucker. And now, 8 out of 10 cases for most people are macular. I think we'll start to develop partial thickness approaches where you'll have a part of the macular retina that you want to replace or do something with and, slice it
So
out.
some form of regenerative or
Right.
restorative cell-based.
Uh-huh.
I think
Yeah.
that's right. It's a
Helped
DSEK for the macula.
helped by contributions with regenerative drugs, neurotrophic growth factors, which failed initially for glaucoma, but in a more precise, targeted way, maybe we can do something for these
I agree
retinas.
with you completely. I think that there are compounds being discovered as we speak or coming to the fore in preclinical work where switches are drugged that help reignite developmental processes. I think that's a fascinating insight, Don. And how about surgically? Where do you think we're going surgically?
Well, I think surgically, every time you say this, there's a massive breakthrough. Surgically, we are at a plateau. We certainly there's continued innovation in, for example, macular hole. Do you fold the ILM flap? Do you insert it? Do you put something in the macular hole? I mean, a million things are going on in macular hole, which is amazing given that we're already in the high 90s or in the 90s for percent success. But surgically, I think that uh, the finest maneuver done by the human hand was in ophthalmology beforehand. It was the peripheral iridectomy, and now it's the ILM peel. I mean, think about that. We've always had the finest maneuver by the human hand. In implantation for in vitro, they use micromanipulators. They do something smaller. But I think we're going to move to a smaller scale and I'm not sure how we're going to do it. It's not going to be the human hand anymore. I don't know about robotics or micro manipulators, but there are things that we see in the retina, whether it's a problem in MacTel or some area in a diabetic that's ischemic. I tried for a long time to do retinal revascularization with tubes and anastomoses in the rabbit retina. It works in the neck, works in your heart, works in your legs, works all over the body. Why can't we revascularize an ischemic macula? Why not? Have we tried it? Well, we don't really have something smaller than 50 microns tubes commercially available, but somebody's going to figure that out, how to revascularize the ischemic retina. I think that would be interesting to try. Um, I also think that we're really primitive in macular edema, really primitive, and somebody's going to figure out something other than anti-VEGFs and steroid and anti-inflammatories. We really need to be able to take chronic macular edema, uveitis, CME, and just eliminate it. Why can't we do that?
Well, we will. We will,
Yeah,
and
we'll.
largely with your help. I'll leave our listeners with one other point about our guest today, Don D'Amico, who taught me a long time ago at international meetings that international surgeons have so much to contribute. And I'll never forget, whether it's at Stano's meetings in Italy or other meetings in Italy or in Greece or other places in Europe, um, and or in Asia, just the approaches that we as American surgeons, if we're open-minded, have so much to learn from the surgical expertise of our colleagues around the world. South America, multiple times, I've watched you, and I took that away from you. Taught me that early in my career, and it catapulted. Now, I trained in Europe, so I had a sort of open mind to learning surgery from the Europeans, but just everything from as narrow-minded as in America, the retina surgeons only do retina, whereas in Europe, they can do everything and do it well, or South America. But speak to that a little bit, Don, about the international contributions and what you've watched and learned people do over the years internationally, because I know that you're a huge advocate of this.
Well, I think you've said it actually beautifully. I got involved in learning Italian and going to Europe because I love my Italian culture. And I didn't learn Italian until I was age 49. Is when I started. And I work hard. I worked at it today. I'll work at it this weekend. I mean, I work still. I'm pretty darn fluent now. And I started going over there with Evan Gregutis to Greece and other friends to Switzerland and Italy and everything. And I started seeing what they were doing. And yes, at the beginning, 25 years ago, they didn't have the endo lasers we had or the things. But the thing that really changed was when we all learned about Relya Zvoinovich. And here was this guy doing these amazing cases, folding the retina over like a taco, cleaning the undersurface, putting it back and getting reattached. And it just caught fire with me, and it's so enriched my life. I've had some 20 plus international fellows. They learn retina. I improve my language skills. That's the deal. And I'm very involved in European ophthalmology and wish to remain so. Now, if you go to the floor retina meeting or many of these meetings, the Frankfurt meeting, now the Verona and Munich meeting, its child. You learn stuff. So 2 weeks ago, I was in Milan at Givre, the Italian Retina Society, and Grazia Pertile showed an approach for a subretinal PVR with massive network of membranes. Massive. It's not going to stretch out with a buckle. This was massive. And what she did was she went across the equator of the globe, put a cannula in, went across the equator of the globe, so no retinal perforation, worked under the retina with forceps and light pipe and everything, cut, pulled, did this, pulled it out, and was able to I mean, is this amazing? I
She's an
didn't,
amazing surgeon, by the way. I
yes,
was watching her at Flow Retina last year talk about where to hold the light pipe and turning down the light in cases of myopic macular schisis. That was just such a great surgical tip. And this is the point. There's such a rich community that we're so privileged to be a part of. And I really think, Don, your embrace of it really is due some credit because you really made it okay for a lot of American exceptionalism to realize, hey, guess what? They know a lot more about certain things than we do. They have a lot to
Yeah.
share with us.
I remember bringing every year we bring one or two international surgeons to the Aspen meeting, and many, them all, bringing Stano and these people too. But the year I brought somebody who was completely unknown to the Americans from the Barracare Institute in Barcelona, Jeroni Nadal. Gironi is a phenomenal vitreoretinal surgeon. He was doing PVR cases, and the faculty, the audience came away from his first talk and said, I could never do those cases the way he did. It's such an exciting thing to discover, like finding a new wine you like or something, that there's talent everywhere. We just have to be, patient and look for it and not have the idea, oh, well, if it's in Croatia, it can't be. No, look, expose, see. I don't know. I never thought of myself as an explorer, but I love learning new things and I love experiencing new people. And as a result, I've become friends and have an international life that, again, I never thought an academic would have.
We're so lucky. And we're so lucky to have had you on Retina Rounds, Don. We could
Oh,
talk forever. I want to be respectful of your time so you can finish your day with something hopefully more productive than a haircut. And thank you very, very much for joining us. And I look forward to seeing you soon, hopefully here in Long Beach at the ASRS, if not sometime soon, and maybe in Europe. So,
oh,
Don,
thank you.
thank you very much. One of the great giants in retina, Don D'Amico. Thanks, Don, for all your contributions. And of course, thanks for your friendship and your guidance. You are the true consigliere.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.